Hello there, my name is Dr. Ferris Pasquini, and I will be presenting social history taking for the NACOSCE. Okay, so we're going to review why we take the social history, how we do it. We're going to review a few transitions we can use, ICE protocol, and we'll have a video example of the interaction live. So why should we take a social history? Firstly, it gives us a chance to connect with the patient as a person. This can show the patient empathy and might allow for the patient to open up a bit more and reveal important information. It could help guide physical exam or test ordering as they might ask in the post-encounter. The information that's revealed could be key to the case, and if we only leave a little bit of time for it at the end, we could be missing out on some important clues. So recognize how vital it is and use it as a tool within your history taking. The other important point is that it helps us get a sense of the context the patient lives in. So it's going to matter if the patient is non-compliant but can't afford their medications. It's going to matter if the patient is having financial hardship and can't support themselves in this specific time. So there are a few important things that need to be covered and will help how you manage the rest of the case. So what should we ask and how do we do it? I've extrapolated this from Dr. Isan's class of the NACOSCE. So this is a quick way to remember what to cover, and the mnemonic is SAD SEXO. So the first component is SAD, smoking, alcohol, drugs, which is probably what you've heard before, what you have to cover in the social history. But also in there, anxiety, depression, suicidality, homicidality. So you're not taking a detailed history, you're thinking of this as a screening process for anything that might be more important and that might need to be delved into a little bit deeper. When you're moving on to this history, always use a transition because they are personal questions at the end of the day, and it could be a little bit shocking for the patient if you move from one topic to another so abruptly. So you could say something like, I'd like to ask a few questions about your social history. Is that okay? Or I'd like to ask you a few questions about your smoking history. Is that okay? Just to transition into the initial social history. And from there, you can transition through each part. So when you ask about smoking, you ask, have you ever smoked before? And you ask the details you need to know for how long, and if they have quit smoking, for how long. So you need to be able to calculate the pack year, and you need to know how long, if they haven't been smoking anymore, how long that has been going on for, to calculate risk for certain preventative measures, or to determine if the patient might need imaging, for example. So it is important. Same with alcohol. Any alcohol use, you can ask. Or do you consume alcohol? And if they do, how often and how much and what alcohol? If the alcohol consumption is a lot, then you can delve in a little bit more. You could do a quick cage questionnaire to screen for alcohol use disorder. With drugs, if you've ever used drugs, if they have, when was the last time you used? Those are important questions, and make sure that when you're answering all these questions, or when you're listening to the patient's answers, that you're controlling your own reaction, because if the patient feels judged, they're not likely going to open up to you. And this again might be key information to your case. About anxiety, depression, suicidality, homicidality, you can ask generally, if you haven't already addressed it in the case, depending on what the specific case is, you can ask simply, how is your mood these days? Do you feel overly anxious? These are just screening questions. You will have to decide if you want to delve into that a little bit deeper. Next is the sexual history. So you will definitely need a transition to start asking these questions. And take note if you're already covering a gynecological history within your case, because this can overlap and you can actually put them together. But if not, then we can ask, or we can open up the conversation by mentioning or asking the patient, is it okay if I ask you a few personal questions about your sexual history? That is a direct question, but also kind of gives the patient forewarning that what you're going to talk about might be a little bit uncomfortable. Some patients don't care at all and are very open, others might not be. But it is best to be direct and to ask the questions you absolutely want the answers from. So here I have listed partner, activity, orientation, STIs. By partner, I don't mean asking if the patient has a partner or not. That could be misleading, because if you're trying to establish if the patient, for example, is sexually active, asking them if they have a partner or a boyfriend or a husband or a wife, etc., will not actually tell you if the patient is currently sexually active. So I would initiate my sexual history with, are you currently sexually active? And from there, if they say yes, then I would ask about the specific partner. Do you have one or multiple partners? And then you can ask about, you can go into STI or the orientation. Are all your partners, are your partners male, female, or both? Do you use barrier protection when you have sexual intercourse? Sometimes saying, do you practice safe sex, is not always clear for the patient, so I like to be direct about that as well. So these are all different ways that you can approach this conversation. I would, if I were doing it, I would practice exactly what questions I would want to ask, the way I want to ask them, in order to obtain the information that I want. So you want to be clear with the patient. And if this conversation makes you a little bit uncomfortable, practice this a lot so that you can get comfortable with it, to be able to maximize the information that you obtain from the patient. The last part of the social history is the O for occupation and living situation. So the important information that we want to get from here is if the patient can financially sustain themselves or not, and what the situation at home is like. So who is living with the patient? What is the relationship like? Is the patient on good terms with everybody? Is the patient safe? So you'll have to gauge as to what kind of like you're looking for, depending on the case and with what information the patient provides. But some questions that you can ask are simply, what do you do for a living? Or are you able to make ends meet? Is there any concern for sustaining yourself financially? Those are some things to ask in terms of occupation. And the living situation. Who do you live with? And how are things at home? Do you feel safe? So those are some quick questions, screening questions, and if you need to delve in farther, you can, based on that. So before I move on, I'd just like to comment on the importance of tact. So I've chosen a quote here from a Canadian-American chemist, and it says, tact is the ability to make a person see lightning without letting them feel the bolt. So it is possible to have uncomfortable and difficult conversations with a patient, and yet the patient doesn't feel attacked or scared or defensive. So it is our responsibility as physicians to be able to allow for a safe space for the patient to express themselves, and that will ultimately help provide the highest standard of care that we can for the patient. So just something to keep in mind. So before we get into the example, I'd like to touch on the idea of ICE, or ideas, concerns, and expectations. These are a great way to gain insight on the situation of your patient, to build a relationship with your patient, or even if you get stuck and you can't really remember what you were saying or the next question you wanted to ask, these are great fallback questions, and you can never go wrong with them. Obviously, you'll have to gauge as to how long your station is and how much time you have. But these can be really good indicators of what you're supposed to be looking for and can make the patient feel heard in their consult with you. So to explore their ideas, you could ask questions about what the patient thinks that they have. With their concerns, you can specifically ask them. Sometimes patients are really all over the place when they're in the clinic. So you can ask them, well, what is the most important concern you have today? With expectations, exploring what the patient wants out of the consult. This is great, especially in a counseling case. So you can ask, what were you hoping for me to do for you today? And that can clarify even at the beginning of your counseling case what you need to counsel the patient on, for example. So this is a really great tool that works for helping you organize the way that you're going to manage your time with the patient, and it also helps the patient feel like they're valued and they're heard. Here's a short example of how this interaction could go.
Okay, so is it okay with you if I ask a few questions about your social history?
Sure.
All right. Do you smoke cigarettes?
No.
And that's never?
I have smoked cigarettes way back in high school, a handful of times. Nothing probably came of that.
Okay. And currently, what's your alcohol consumption?
I do like red wine.
Mm-hmm.
I will have a glass of red wine, like 1 or 2 glasses a week.
Okay.
Mm-hmm.
1 or 2 glasses of red wine per week.
Mm-hmm.
All right. And what about recreational drug use?
Never.
Okay. And marijuana? Does that exclude marijuana? Or?
So I have tried marijuana again in high school a handful of times. Nothing ever came of that.
Okay, but no other drugs you've tried?
No.
Okay. I'd like to move on. Would it be okay if I ask a few questions regarding your sexual health?
Sure.
Okay. So currently, are you sexually active?
Yes.
Okay. And is that with one partner or multiple?
One, my husband.
Okay. And that's an exclusive relationship?
Yes, it is.
Okay. And at some time during your current relationship, marriage, have either of you been tested for STIs?
Yes, I have.
Okay.
Yeah.
And is there any concern there?
No concerns.
Okay, perfect. All right. And is it okay if I ask about what you do for a living?
Sure.
So where do you work?
So I'm a social worker.
Okay.
I work in mental health at a hospital in Grimsby.
Okay, great. Very rewarding work, I imagine.
Mm-hmm. Challenging at times and rewarding at others.
Yeah, that's great. And is there any issues for sustaining yourself financially?
No.
Okay, no issues there. Okay, perfect. And what is the situation like at home? Who do you live with?
I live with my husband and our daughter.
Okay. And is anyone else living with you? Do you have any pets?
We have a pet, a dog.
Okay. And what is the dynamic like at home? Do you get along well, or are there any issues?
Things are well at home. We get along. We are like new parents, so balancing parenthood and what that looks like for both of us can be a challenge at times, but otherwise we communicate fairly well and there's no issues in the home.
Okay, great. And just to confirm, you feel safe at home, right?
I do feel safe at home.
Okay, yes. Great. So just before we finish with our history and move on to our physical, I'd like to ask you, what do you think the issue is today? I know you're here for fatigue. What do you think it is?
I wondered about my thyroid and if there's something wrong with that. I also wondered about my B12 and whether or not that's low. I do have a history of that being low. So would like to get on top of that. And I also haven't been working out as often as I typically do. So I'm wondering if between that and I'm eating a little bit more sweets lately, if that could be contributing to the fatigue as well.
Okay, those are all valid, and most likely we will look into the thyroid and the B12 as part of our lab workup, and we'll see what comes out of the physical exam as well. And always working on our diet and exercise is going to help make us feel better. So those are good things to keep in mind, even if we find something else that's contributing to this fatigue. And so your main concern today then is the fatigue itself, or is there some other concern that you have?
It's mainly the fatigue. We are trying to get pregnant again. Okay. However, it's only been 3 months, so I'm not too concerned about that yet.
Right.
Although it is something in the back of my mind there, but primarily the fatigue.
Okay. It's good to know that you're trying, and I'm going to ask, do you take multivitamins?
I do, yeah.
Okay, great. That's perfect. And how long have you been taking those multivitamins for?
I believe I'm in the 3rd month of taking them.
Perfect timing. So basically, we recommend that you are taking those multivitamins, specifically the folic acid, 3 months before you get pregnant, and then throughout the pregnancy. And that's just to help with specifically the neural development of the spinal cord and the whole nervous system of the baby. So that's great that you're already on top of that. And so finally, I just want to ask, what are your expectations out of your visit today?
I would like to have blood work done, just to rule out any thyroid issues or any B12 issues. And with that ruled out, then I can focus more strictly on kind of the diet and exercise piece.
Okay. So we'll do the physical exam. We'll see if anything comes up, and we'll order our labs, and we'll take it from there. How does that sound?
That sounds good.
Okay, great. So I'll get you to get on the bed, and we'll check you out.
Okay, great.
All right, so that's social history taking for you. Don't forget SAD, SEXO, and ICE. You can get the context, gain empathy with the patient, provide the patient with the best standard of care, and even get some clues regarding testing, management, and compliance. Thank you so much for your time, and good luck on your exam.